But we are here in the psychopharmacology workshop are mainly focused on what we call molecular level understanding about what is happening in the field in addiction in the brain. And to be able to do that, we need to have an understanding how glutamate, how dopamine, how GABA, how norepinephrine, how opioids, they are interacting in the brain and how we can modify them with different medications. And this is going to be most of our discussion today, right? Meanwhile, we have what we call process level understanding of the brain. So far we mentioned circuit level understanding, molecular level understanding, and also we have process level understanding in terms of how negative valence is processed in the brain, how positive valence, how control happens, how you do appraisal in the brain. And these sort of process level understandings are very important when you do therapy, right? When you do different sort of psychotherapeutic interventions or cognitive interventions or behavioral interventions, you need to know how these sort of different processes are happening in the brain because we target them with different psychotherapeutic interventions. But the reality is these levels in terms of the process level, molecular level, and circuit level can also combine together in what we call mechanistic frameworks, in a way that how different things are working together from the molecular level, from the circuit level, from process level, and why it is important. If you want to combine different sort of treatments together, now the field is moving towards that. In terms of you are prescribing a medication, meanwhile you might be able to put them on a TMS intervention, and also you are adding behavioral interventions like contingency-based management or CBT or other things. And you need to understand how different types of interventions are working together. And to be able to understand that, you need to have what we call a mechanistic understanding about how these different levels are, at the end of the day, they work together and they interact with each other. Let me just give you one example. Within these sort of mechanistic frameworks, for example, we have what we call kind of dorsolateral prefrontal cortex and glutamate in dorsolateral prefrontal cortex. So we know that the level of glutamate in the DLPFC changes with alcohol use. And that specific connection to subcortical area is important in what we call exerting effort for controlling craving. And meanwhile, we can target that with things like TMS to modulate top-down regulation. So there is a specific marker in the brain, which is the level of glutamate that you have in DLPFC and the connection that we have from DLPFC to subcortical area as what we call biomarker. So this is what we call biomarker in the brain. And this is not the only biomarker, addiction-related biomarker, but there are multiple of those biomarkers that they can combine our mechanistic understanding about brain and different interventions. I'm not going to go to all those details and go to the kind of technical details of those biomarkers, but just giving you an understanding, especially for those who are residents of psychiatry. Some like half of the people in the room are residents of psychiatry. So that is the future of psychiatry in terms of we go for a specific quantifiable measures from the brain that can bring different levels of understanding from molecular, from circuit level, from process level, and combining together those areas. We have a new paper in Nature Mental Health discussing about all those biomarkers, specifically in the field of addiction, if you're interested. But what we do classically in clinical practice in addiction psychiatry, we have what we call another level 4, which is clinical understanding about addiction, right? What we have in DSM-5. How many criteria we have in DSM-5 for substance use disorder? 11, right? So those criteria, for example, failure to control, failure to stop, and also too much desire, or what we call craving. These are 3 of those criteria. These 3 criteria that are mainly related to lack of control could be also connected to that specific biomarker that I was mentioning in terms of the connection, the glutamatergic connection between dorsolateral prefrontal cortex and subcortical cortex. But we also have other criteria, things like the different levels of consequences that substance use can make in your life. Time consequences, work-life consequences, social consequences, functional consequences, risk consequences in daily life, physical consequences, physiological consequences, and also what we call withdrawal. So these are the 11 criteria that we have in DSM. And these are the clinical presentation of the patients that we have. And we try to consider them when we are doing the treatment for our patients, right? So that is the way that we are doing in the clinical work. But in psychiatry, when we discuss about those criteria, for example, when we talk about major depressive disorder, how many criteria that we have for major depressive disorder in DSM-5? Anybody remembers? That is something that you do in the daily practice, right? So it is just 9 characters. So we have, those who are medical students, they say come CIGE CAPS, they have some 8 criteria there. But there we already have 9 criteria, right, in DSM-5 for major depressive disorder. But other than these 9 criteria, we have some what we call specifiers, right? So what are the specifiers that we have for major depressive disorder? Anxious distress, correct, 1. What else? With psychotic features, right, what else? Melancholic, correct, what else? Catatonic, what else? Atypical, fantastic. So melancholic features, anxious distress, mixed features, those who are getting close to kind of mania, being agitated, that's the line of work. With psychotic feature, catatonia, seasonal pattern or atypical, and peripartum onset. So these are the major specifiers that we have. But meanwhile, there are discussions about new specifiers, like whether they have inflammation or not. And we know that there something like 1/3 of patients with kind of major depressive disorder, they have extended level of inflammation, and that could be an important characteristic for the way that we are treating them. Or, the medical aspect of their treatment that we need to consider. And also those who have history of trauma. And we know that these sort of specifiers, they change the way that we prescribe medications for people in the context of MDD. As an example, for example, we know that when we have a patient who has MDD with a history of trauma, we usually when we prescribe medication, we know that SSRIs still work, but they do not work in a quality that they work in people without having history of trauma. And even now there is a good level of evidence that potentially the medication that they have glutamatergic pathways, they are more effective for those who have history of trauma when we are treating their depression. Okay, so this is the way that we use specifiers to optimize the treatment based on those specifiers. Or when we have anhedonia while people have depression, how that is informing the way that we are prescribing medication. So that specific melancholic feature is informing us about the medication that we want to use. As an example, we know that SSRIs, they are not really good for anhedonic features, except 2 SSRIs that they have a little bit of evidence that they might address the anhedonic feature of depression. What are those SSRIs? Sertraline and fluoxetine, these 2 SSRIs. And what is the reason behind that? They have some dopaminergic kind of features, that they have some initial kick when you prescribe them for your patients. Anybody who prescribes pramipexole for those who have anhedonia, any experience in prescribing pramipexole? Okay, pramipexole, I work in a TRD clinic with kind of treatment-resistant depression clinic. So for extreme cases with anhedonia, one of the things that sometimes we try is pramipexole. And I have patients that they respond to depending on the patient's kind of situation, kind of 0.5 milligram up to 5-6 milligram of pramipexole. And then other things that they have higher level of evidence, bupropion, venlafaxine, methylphenidate, those things they have higher evidence. And the highest level of kind of evidence is for another group of medication that they are more effective for anhedonic part. So based on that specific specifier, we optimize the medications, right?